So our research study will be the effect of deep brain stimulation pulse frequency in adults with early intermediate stage of Huntington's disease.
Our research question is how does changing Okay, what did I do? Sorry, man, we'll start over.
Did I say good afternoon the first time? Good evening. So our research will be the effect of deep brain stimulation pulse frequency in adults with early intermediate stage.
Our research question is how does changing the pulse frequency of deep brain stimulation of the globus pallidus intimus influence chorea in patients with early intermediate stage Huntington's disease? The significance of this proposal is to improve people with Huntington's disease quality of life. Usually when patients with Huntington's disease start to develop tremors, they can't do basic tasks that we need to do. But if you go and help to solve that problem or fix it, you could make them be able to do the normal tasks that they need. The purpose of the goal of the study is to learn how the pulse per second induced brain stimulation can change the reaction in the maximal period.
Before we get into the experiment itself, we do need to provide some background information as context.
So, Huntington's disease is an autosomal dominant neurodegenerative disorder, and essentially how it works is it's a mutation on the Huntington gene on the 4th chromosome. So, there's this thing called a CAG repetition sequence, and essentially in Huntington's patients, they have over 36 repetitions of the CAG trinucleotide sequence.
One of the characteristics aspect of Huntington's is a neurological disorder known as chorea. This involves jerky, involuntary, and uncontrollable movement of your muscles, especially in your limbs. Huntington's also develops in stages. We chose to focus on stage 2, also known as early intermediate. In this stage, chorea is worsening, and the ability for patients to live their own lives, doing things like communicating, basic movement as I'm doing now, and just live autonomously is seriously threatened. At this point, they need either a part-time assistant to live or work full-time. As it eventually advances to stage 5 at the end-of-life stage, although the chorea is reducing, processes like bradykinesia and akinesia threaten their lives, and the leading cause of death for Huntington's patients is aspiration pneumonia, and the second leading cause is suicide. The physical symptoms and psychiatric symptoms are extremely pale, which is why we're here. Because Huntington's does not have any cure, there's no way to slow the advancement, but we aim to further understand its functions to improve the quality of life for patients.
Okay, so meet the anatomy of one of the most complex structures I've ever sort of Google scholared in my entire life, right? So Huntington's disease kills cells in inhibitory cells in the striatum, also known as medium spiny neurons. These suppress involuntary unwanted movement. So when Huntington's disease impacts this, you get those random jerks and choreography-like movement. So the striatum is made of the putamen and the caudate, also, which are two structures in the basal ganglia, and that's located deep within your cortex. So it's not as simple as this, though. There's circuits inside the basal ganglia, known as the direct circuit, the direct pathway, and the indirect pathway. The indirect pathway is responsible for suppressing those involuntary movements, while the direct pathway is excitatory and causes them. So a good balance between these two pathways would result in the smooth motor function diagram.
So this diagram has kind of saved us these past few days. So I'm going to be explaining how the direct pathway works. So you get an excitatory signal from the cortex that is sent into the striatum, and then you get an inhibitory signal sent to the globus pallidus internus. So the globus pallidus interna is an inhibitory structure, like naturally. So when you have an inhibitory signal sent to an inhibitory structure, it's like a double negative, so you get a disinhibition into the thalamus. So because of the disinhibition into the thalamus, you get an excitatory signal sent into the cortex. So basically what we're trying to do with this research is we're going to have less inhibition into the thalamus. So that way when you have less inhibition into the thalamus, you have less excitatory signal being sent to the cortex, and hopefully that means that there's less involuntary movement and motion in Huntington's patients.
So the procedure we're going to be using to possibly help do this is deep brain stimulation, which is invasive surgical procedure. So basically, the surgeon will be putting leads in the area of the patient's brain to stimulate those parts. And so they will also be implanting a stimulator in the chest area of the patient. So this stimulator would generate electrical pulses to those leads to actually stimulate the brain. And so we're hoping to do this and stimulate the GPI.
So we've hypothesized that deep brain stimulation, specifically 150 hertz as a pulse frequency to specifically the globus pallidus interna, can help reduce the chorea, specifically maximal chorea, which is those jerky movements in patients with Huntington's disease. So with that in mind, now we can get to the methodology of this experiment. In this experiment, we're basically changing the pulse frequency of DBS, which is measured in hertz, and seeing how that impacts the maximal chorea severity, which is basically measured using the Unified Huntington's Disease Rating Scale test, which is a scale that measures chorea from a scale from 0 to 4. Some of the control variables in this experiment include the sample group size we chose, the time period DBS is used, and the DBS device used in the deep brain stimulation. In this experiment, we'll be using Medtronic's Percept, which is approved by the FDA in 2020. So our test sampling. We have 60 participants, 30 men, 30 women with stage 2 Huntington's disease. The criteria to participate is that they have to be over 30 years old. My good friend Jonathan will explain why in a second. And they also need to have approval from a movement disorder by the neurologist in order for deep brain stimulation. We also need that the number of codons in CAGPP sequence mutated chromosome 4 is between 36 to 50 repetitions. Finally, we also need that for the participants to not be taking drugs to improve their conditions in the previous 8 weeks before the study. Some exclusion criteria includes having severe memory or cognitive issues, pregnancy, or previous implantation of a pacemaker, which is going to affect the patient.
So we looked at a study from Heinrich University, which basically did DBS on the GPI to help create Huntington's, and so we were using that and based on methodology.
And so, with that in mind, we are first going to have patients without any DBS in place or implanted. And we're going to have an initial rating using the rubric description I previously stated, to basically measure their maximal chorea subsection, which is one of the criteria explained in that stated rubric. We have 3 groups. Each group will be randomized with 10 men and 10 women. And
So group 1 will be having DBS with a pulse frequency of 150 hertz. Group 2 will be using 130 hertz, and the control group will be using 100 hertz.
This is because Dr. Pagan mentioned to us that the standard for DBS is 100 hertz and the overall extremity would be 180. So we're trying to find some neutral ground in there not to overextend.
And And we chose the higher frequencies because from studies that we have seen, it's shown that higher frequencies are more effective in improving motor conditions.
All groups will follow the same DBS schedule and will have a follow-up every month for active DBS for a period of 8 months. And each follow-up will measure the severity of their chorea, whether it's improving or not. Some limitations. An issue that we have right now is that there's a lack of representation in our study group. Like I pre-mentioned, we have a situation where we're taking into consideration the 30 age group. And
Yes, so there is another condition known as juvenile confusion, which refers to patients who see the onset of symptoms before age 20. They have more than 50 CAG repeat extensions. One of our limitations of the study is that our criteria requires that the participants are age over 30 and that the number of CAG repeat extensions are between 36 and 50. So we are neglecting this population.
Another limitation of our study is geographical limitation. By its nature, TBS requires a neurosurgeon to implant a simulator into the brain, and naturally that's not accessible in every clinic across the country. So were this to become an actual technique used to help with Huntington's around the country and potentially further, that is something to consider, the accessibility of neurosurgeons.
After a consultation with, discussion with Dr. Fernanda Fernand, we did learn that the issue of studying chorea specifically in Huntington's is largely limited to clinical human study rather than an animal model like mice. So that is also a very important, very significant limitation as experimenting on humans brings a lot more ethical questions than an animal model.
So Huntington's has other effects and symptoms besides just chorea and movements, including cognitive and memory-related symptoms. And our study is specifically just focusing on the chorea, specifically maximum chorea. And this is because we chose chorea because the chorea has a great impact on the patient's quality of life, as the press mentioned. It has a great impact on the patient's quality of life and autonomy. And we're hoping that we can help increase their autonomy and quality of life, that it can help bring back their sense of self to what it was before they were experiencing symptoms.
Another potential refutation of our research proposal is the use of pharmacological therapies. The only FDA-approved drug to help treat the caloric movement due to Huntington's is tetrabenazine. Although we acknowledge that tetrabenazine is cheaper, more accessible, and less invasive, we also want you to understand that we are looking to further understand the functions of Huntington's, further improve quality of life in an alternative way, and hopefully in the future develop more advanced therapies that can even do things besides just quality.
Okay, so with this treatment comes ethical, legal, and social implications. Okay, so for ethical implications, since DBS is a very invasive treatment and it targets the nerves, targets the brain cells using lead implants, there are some common complications that could occur, including hemorrhage, infection, and the breakage of lead implants. Moreover, there are common personality shifts like depression, memory impairment, aggression, and more speech disturbance. So these sort of side effects can lead to more severe injury and even death.
I also do want to mention that this experimental treatment, the patients involved must be well informed. We cannot frame this as like a cure-all miraculous therapy. We need the patients to truly understand the risks involved and to understand that results aren't necessarily guaranteed. So they need to make an informed decision.
Okay, so typically DBS implants are around $10,000 to $30,000, so they're considered very expensive. And so surgical complications can occur if these lead implants lead to death. And so these doctors, specifically neurosurgeons, can lose his or her medical license. Moreover, we want to consider if a patient gets a DBS implant, does that change his or her identity? And what do I mean by this? Well, let's say hypothetically speaking, a patient gets the implants and they start to commit more crimes because, like, as we say, aggression is a symptom of EPS. So in this case, one may argue is whether or not the crimes are caused by the person or the EPS symptom.
So thank you for paying attention to our presentation. Here are the references. The group would also like to say, to express our apologies to Dr. Pagan for basically going straight at him with bullet questions to get him very excited.
You loved it, by the way. That was great.
We'd also like to give a special thank you to Dr. Worsman, who have endured late nights with us to help us figure out that entire anatomy and circuitry.
Hey.
Absolutely excellent. I mean, this is the kind of thing that I would expect to see coming out of Dr. Oken's lab group. Perfect. I mean, it's right on. I mean, it is right on. So I have nothing, I mean, well presented, super clear, really good understanding of how to use DBS as its own control, really, really good presentation in terms of how you want to do the subjects. Just overall, stellar. 10 out of 10. Great job. Great job. John, what'd you think?
Oh, agreed. With the ethical questions that can come up, I think you're fine on most of it. We're kind of like, yeah, that can be overcome. This business of self-identity is going to become important, but it's not a problem, it's not a bug, it's a feature of what you're doing, because what you can find is that some patients will report improvement of their own self-identity with the restoration. Others will, their needle will go in the opposite direction. They feel like they are too quickly becoming somebody else because you're manipulating the own internal sense of bodily control. But you can't prevent that. But what you can do is measure it and get more results. So some sensitivity to the personal self-identity, but don't treat this as a limitation. Treat it as an opportunity. Other than that, I think you're covered on the ethical issues.
Moni, what do you think?
The thing that I love most about this presentation was your well-defined inclusion-exclusion criteria, and that you narrowed it down to a very specific subset of the Huntington population. So it resonated with me that you took a lot of time with that area. So well done. Great job.
Faye?
I wish you guys had taught me about Huntington's like 4 weeks ago when I needed you a lot. No, the way that you described the indirect and direct pathway was very well articulated. I saw a lot of heads nodding over here. They're like, wow, yeah, they really nailed it. So being able to talk through that is such a great step, and you really, by organizing and communicating it clearly, I was able to get so much out of that presentation. So thank you for doing that.
And last but certainly not least, someone whose license plate used to be striatum.
Don't ever make your thesis topic your license plate. Your experiments won't work for another 4 years. You guys did great. You did a great job. You were an absolute blast to work with on those circuits. You took a topic. You said, no, I really want to dig into that. I'm like, okay, but this circuit is really hard to understand. It's not going to be possible in 24 hours. And you guys said, yeah, we want you to try anyway. So, and I happen to know that there was a lot more you could have explained in it, and I know that it was I who kind of put the fear of death in keeping this within the time boundary. So I know that you sacrificed a little bit of that for simplicity in this, but you maintained the essence of the balance there. The only ethical, like everything, the way you led into everything that was professionally presented. The only ethical thing that I would add on to that is issues about the continuity of care. What if this actually does work? Yeah. And what do we do after the end of the study? Yeah. Is there funding for them to continue to go see a neurosurgeon to replace the battery, to update, update the stimulation, things like that? Or is it going to be ethically required that they have the stimulation removed at the end of the trial because nobody can do it? And what's the implication for their, again, on their agency, on their identity when it's taken away from them? And what kind of psychological continuity of care are we providing to people for this?
So to answer that a little bit, so with our discussion with Dr. Pagan, he basically told us that at least that part of in the deep simulation, that battery lasts for approximately 5 to 15 years. He actually gave us an example of a patient from he made the surgery 22 years ago, and he's the oldest patient, and recently he came in for a replacement of the battery. So with that in mind, we could, in a sense, deal with that ethically, but it is a very important concern that we want to also
Cool.
bring up.
Sure, yeah.
Good job.
Yep.
Good job.
Great job, guys.